Recording in progress. Divya, you had called UMS, sir?
I'll just call sir now. I'll just call him and say.
Yeah, and Lakshmi, sir, I will call.
Yeah, and Lakshmi, sir, I will call them. You call.
Okay, sir.
Okay, it's not coming up. My slide. Right.
And in the meantime, we would like to thank all our speakers and panelists for agreeing to spare some time for this session.
Thank you, sir.
It's a pleasure.
Yeah, slide is not coming up.
No.
Achha. Otherwise, you send.
Now, can you see my slide?
Yes,
Perfect.
yes, sir.
It is visible.
Can you just move your slides, sir?
Yeah.
Yeah.
Perfect.
Yeah, that's it.
Yeah.
Divya, you got hold
Sir,
of.
sir is not picking up the phone. So.
I will try one for once, and then if sir is busy, then you can start now. I will request sir if he's there. Lakshmi sir also I'm not able to reach.
Madam, I have sent on Telegram. Can you please check?
Okay. Yeah, I'll just check.
हाँ, आशीष का तो पक्का से ले लो उसका आशीष का एक
Sir,
दो
now-
कॉपी लेके रखो
Now I sent on
Hello.
Telegram. It has gone in 1 minute. I don't know why the connection is not.
We want to hear you. Last time we could not hear you because of poor connectivity.
Your call has been.
So I think sir must be busy, Divya. So shall we start?
Yeah.
Huh?
Yes.
So you can open and you can start, Divya.
Yeah.
So we're all set now.
Asmita, you can.
Divya,
I think we have
PowerPoint is working now. All the PowerPoints are working, is it?
Yeah, only Ashish is there. That I think should work. Anyway, it's working. Only there was a small patch.
So you can take
it's
over.
fine.
Maybe you can project from your side. Is that possible in
Yeah,
case?
I'll do that. I am downloading it, so I'll just keep it ready in case there is a patch. I will do that.
So please start then. I think we should start. Yes.
Asmita, you can open.
The room is open, ma'am. You can start.
Good evening, all. Every year on April 11th, the World Parkinson's Day is commemorated as the birth anniversary of Dr. James Parkinson, the British physician who first described the disease in 1817 in his book, An Essay on Shaking Palsy. So this month is basically celebrated as Parkinson's Awareness Month. And basically multiple activities are carried out in promoting research and advancements in therapeutic care in the field of Parkinson's disease. So I'll just share one slide. Yeah, so hope you can see my slide. So this is you can see my slide, right?
Yes. Very much.
So
very nice.
This is the red tulip, which is the official symbol for Parkinson's disease, which represents love, hope, and resilience for patients with Parkinson's disease. And it was adopted as the global symbol on the World Parkinson's Disease Day in 2025 and is often used to promote the awareness during April. Now, the theme for World Parkinson's Disease Day in 2026, that's today, is the Bridge the Care Gap. This focus basically highlights the urgent need to improve access to specialized care, affordable treatments, and support systems for people who are living with Parkinson's disease. And it aims to foster equitable healthcare and increase awareness of early symptoms. So on the occasion of World Parkinson's Disease Day, the Indian Academy of Neurology Movement Disorder Subsection, we would like to spread the awareness amongst the group of residents, general neurologists, physicians, psychiatrists, all of whom are part and parcel of this important aim and that is treating and bringing hope to patients who have Parkinson's disease. So we will be basically focusing on Parkinson's disease management. How do I do it in a case-based approach? So we'll be running through a few topics as well as the panel discussion. So to officially welcome you, I invite Dr. Neeraj Kumar, who is the professor at AIIMS BB Nagar, to carry on the proceedings.
At the outset, I would like to thank Divya for taking all the pain for this program and for creating this nice program. And I am sure that the audience will definitely love the program. And we have all eminent speakers here with us, and from north, east, south, west, all parts of country. And I think without much wasting of time, I would like to invite everyone and enjoy the program. And please feel free to put your comments in the comment box and ask any questions from the experts. So I would request Divya to please carry on with the program. Yeah.
Yeah.
Please, Divya.
So, yeah. So I'll just introduce the first speaker. So our first speaker is Dr. Priyanka Samal. She's an assistant professor at Department of Neurology, AIIMS, Bhubaneswar. As we know, she's a young, dynamic researcher who has done her DM neurology from AIIMS, New Delhi. And she has 25 publications, and she has also earned the Best Research Presentation Award at the MDSAOS Basic School. So she will be talking to us about how we manage Parkinson's disease. Basically, we will be dealing with the diagnosis of Parkinson's disease. Over to you, Priyanka.
So before Priyanka starts, I could not see on her this introductory slide the award which she won at MDS Olympics, I think last year. No, you won silver medal. Is it? Am I right or wrong? You are not audible. You are unmute yourself. You unmute Priyanka. You are muted.
You are still muted.
Am I audible now?
Yes.
Yes, I did not mention that. on
So
slide.
many awards you have won. You forgot to mention this, right? It's a big award. Chalo, please carry on.
Thank you
So
so
she
much.
proudly
Very
won
kind.
the video challenge medal last year at
Yes.
Hawaii in the MDS video challenge.
Very few from India have won, and Divya is one of them, I think. So please carry on.
Thank you. Thank you. At the onset, I would like to thank the Iron Movement Disorder Subsection for giving me this opportunity to talk on how to diagnose Parkinson's disease, a topic which remains very close to me because Parkinson's disease is almost the second most common neurodegenerative disorder and is fast growing. So the diagnosis of Parkinson's disease, the burden doesn't lie just on movement disorder specialist or neurologist. Even physicians, even I think MBBS students should also know how to diagnose Parkinson's disease. And I hope after listening to this talk, you have some impression on how to diagnose Parkinson's disease. This is an outline of my talk. So as Madam has already said, today we commemorate this the birthday of Dr. James Parkinson, who according to the Western literature was the first one to give the most succinct description of the clinical symptoms of Parkinson's disease way back in 1817. But I would also like to share on this platform that what the Western literature doesn't know about is that way back in 600 BC also, there are accurate descriptions of the Parkinson's disease symptoms in Sushruta Samhita and Charaka Samhita. And also there is a description of the treatment of the disease. The seeds that they use, the Mucuna pruriens, actually contains levodopa. So yes, this is a very old disease. It has been present since time, long back. And the accurate description that is recorded was in 1817 by Dr. James Parkinson. And in his memory, John Martin Charcot coined the term Parkinson's disease. So for today's talk, I would like to first differentiate between what is Parkinsonism and Parkinson's disease, which is a term which confuses MBBS students and even early MD medicine students, whereas Parkinsonism is a constellation of motor symptoms, and the diagnosis of Parkinson's disease requires that whether there is Parkinsonism in the first place, whether there are the motor symptoms which is sine qua non with the diagnosis of Parkinsonism or not, and then we decide whether Parkinson's disease or not is there or not. What we can say that Parkinsonism is a symptom complex, and Parkinson's disease is the most common cause of Parkinsonism. So this is the textbook picture of Parkinson's disease, the mask-like faces, the forward tilt. It is the same description that has been going on since centuries, and till date it remains the same, that Parkinson's disease is essentially a motor disease. The core criteria of Parkinson's disease remains motor. But gradually, as our understanding of Parkinson's disease evolves over time, now we know that there are myriads of other symptoms, the non-motor symptoms, which we either don't detect or we don't talk about, or the family or the caregivers don't talk about. And also that Parkinson's disease is not just a disorder of the dopamine only. There are other neurotransmitters also which are responsible for Parkinson's disease. So with the evolution of the understanding of Parkinson's disease, the evolution of the diagnostic criteria of Parkinson's disease also occurred. Way back in 1988, depending on the findings of the brain bank, that is a biopsy-proven Parkinson's disease, the UK brain bank diagnostic criteria of Parkinson's disease came. Here also the core was the motor criteria, where bradykinesia was essential with at least one of the following, that is rigidity, rest tremor, and postural instability. Then there was the exclusion criteria, any one of these, and we cannot make a diagnosis of definite PD. And there were some supportive criteria. We needed 3 supportive criteria of this. I'll be talking about this in detail. So what I want to emphasize is that Parkinson's disease diagnosis is largely a clinical diagnosis. Even today, for making a diagnosis of Parkinson's disease, we don't need an armamentarium of investigations. What we need is clinical acumen. But inherent to the diagnosis of diagnosis of Parkinson's disease is that there is a variability in diagnostic accuracy. There are studies which have demonstrated that the diagnostic accuracy depends on a number of factors. It depends on the disease duration, whether the patient has come for the first time versus a person who has been coming to you for 2 to 3 years, and now you're sure that the symptoms are fitting into Parkinson's disease. It depends on the age of the patient. It depends on who is making the diagnosis, the expertise of the clinician, somebody who has seen just 3 or 4 cases versus somebody who is seeing 300 and 400 cases. And also the evolution with of understanding of the disease also affects the diagnostic accuracy. So with the evolution of the diagnostic accuracy, we to incorporate all these factors, the MDS came up with the MDS clinical diagnostic criteria in 2015. And for the rest of my talk, I'll be mostly focusing on this diagnostic criteria. So for the diagnosis of Parkinson's disease, what we first need to do is diagnose Parkinsonism. And Parkinsonism, we need to have the motor symptoms. And the motor symptoms is bradykinesia plus either rigidity or rest tremor. Then there are red flags and green flags. We know that there are some absolute exclusion criteria and there are some red flags. So let me talk about this one by one. First of all, the core clinical criteria that we need for Parkinson's disease diagnosis is bradykinesia. Bradykinesia, as the name suggests, means slowness of movement. I hope the video works. So it means slowness of movement. And when we do ask the patient to do certain tests, like we ask them to do a finger tap, then there is decrement in amplitude or speed. Like you can see in this lady, there is mask-like faces, and compared to the left hand and the right hand, there is some decrease in amplitude and speed, and she is not able to do. So asymmetric bradykinesia goes more in favor. Bradykinesia is a core clinical criteria. We do need to have bradykinesia in order to make the diagnosis of Parkinson's disease. Then with bradykinesia, we need either rigidity or rest tremor. So for examination of rigidity, the patient needs to be in as relaxed position as possible. That is easier said than done in a busy clinical setting. But rigidity needs to be seen as a slow, passive movement of the major joints with the patient absolutely relaxed, where the examiner manipulates the limb as well as the neck. We often forget the neck and the trunk. And what we expect is a lead pipe resistance, a resistance which is present throughout the movement. It is independent of velocity. Mind you, if there is only isolated cog wheeling without lead pipe rigidity, now the MDS diagnostic criteria says that that is not enough to classify as rigidity. However, what we can actually interpret from that is that it reflects an incidentally detected rest tremor. That is a symptom of rest tremor. Then coming to rest tremor is a 4 to 6 hertz. Okay, This video is not working. Rest tremor, as we all know, it is a 4 to 6 Hertz tremor. We cannot count the Hertz, but what we know that it is present at rest. Now, this examination doesn't come when the patient comes into your room. It can actually start in the waiting hall when the patient is actually resting and waiting for you. There are various studies which shows what exactly a resting limb is, whether it is an arm lying in the armrest or arm lying in the lap. But what I want to emphasize is that we have to observe the patient for some time, because sometimes the tremor is not visible immediately. But after some time, after talking to the patient, gradually you notice that when the patient is relaxed, then there is a rest tremor. As soon as the patient is starting to make the movement, the tremor subsides. Now, rest tremor is essential. If there is only kinetic tremor and postural tremor without rest tremor, then that doesn't qualify for the Parkinsonian criteria according to the MDS 2015 criteria. Postural instability previously was a core part of diagnosis of Parkinson's disease, but gradually with the new diagnostic criteria, it has been removed as a part of the core clinical criteria, because if there is early postural instability, the diagnosis of Parkinson's disease is actually doubtful, but some amount of postural instability does set in as the disease progresses. Then there are a list of negative criteria. I did not talk about them previously. Now what I would like to emphasize is that the exclusions criteria are divided into absolute exclusion criteria. If you have any of these criteria that are enlisted on the screen, that is, if there is unequivocal cerebellar abnormalities or a supranuclear gaze palsy, or if there is any diagnosis of behavioral variant FTD, or just the lower limbs are involved and the upper limbs are not involved, if there is long-standing history of drug known to cause secondary Parkinsonism, or if there is no response to levodopa, high dose of levodopa, in spite of giving a moderately severe, in spite of having a moderately severe disease, if any of these criteria is present, then we cannot make a diagnosis of clinically established or probable Parkinson's disease. Then there are a list of supportive criteria. If there is clear and dramatic beneficial response to dopaminergic therapy, for that we have to do the MDS UPDRS score. Now it is advisable to do the MDS UPDRS score in which the patient is actually asked to, ideally the patient should be off levodopa carbidopa, and then in the morning he's taking the 1.5 times the morning dose, and then we do the MDRS UPDRS 3 score, and if there is a good response, that is more than 30% response, then we call it a clear and dramatic beneficial response to dopaminergic therapy. Presence of levodopa induced dyskinesia is also one of the core supportive criteria. Also, if we find that there is no history of rest tremor, but on examination we find rest tremor, that is a supportive criteria. Now we have ancillary test also as part of the diagnostic criteria. The presence of either olfactory loss, or on an MIVG scan, if you find sympathetic denervation, these tests have more than 80% sensitivity. So now these are included into the as a supportive criteria. Mind you, they are not necessary to make a diagnosis, but they do serve as a supportive criteria. Now, this is just an example of what a dyskinesia looks like. In contrast to tremors, what I would like to highlight is that just don't go with history. Do encourage your patients to make videos and come to you, because in local language, vernacular language, some people can call this also tremor. So you exactly don't know whether you're dealing with a rhythmic movement, which we know is tremor, or you're dealing with a continuous flowy movement after taking the drug. Also, it is necessary to take the history that when it is occurring after taking the drug. But as a part of diagnosis, we know that presence of dyskinesia makes us more confident that we're actually dealing with a case of idiopathic Parkinson's disease. Then there are the list of red flags. If there are any of these red flags, if there is rapid progression or there's no progression, if there is early bulbar dysfunction or any inspiratory stridor, severe autonomic failure within the first 5 years, then these are markers that this could be something else. This could be one of those in Parkinson's plus syndrome. Then we think that this may not be Parkinson's disease. However, these are just red flags. If you have one red flag and one supportive criteria, you can still go ahead with the diagnosis. Now we know that nowadays the internet is flooded with red flag in relationship and green flag with relationship, or red flag in a workplace and green flag in workplace. So here also we have red flags and green flags which can be counterbalanced. So if there is one red flag and one supportive criteria, you can still go ahead with the diagnosis. If there are 2 red flags and 2 supportive criteria, you can still go ahead with the diagnosis. But if there are more than 2 flags, red flags, then we cannot make a diagnosis of clinically probable Parkinson's disease. So either we make a diagnosis of clinically established Parkinson's disease with a 90% specificity, in which there are no red flags at all, or we make a diagnosis of clinically probable Parkinson's disease with a 80% specificity where red flags are counterbalanced by green flags. Now, is it all? Have we diagnosed everything? No. We are still missing the prodromal Parkinson's disease, where symptoms are present, but they are not enough that we make a diagnosis. And actually, it is necessary to that we identify these patients. Number one, because this is where we can intervene. Till date, we don't have an absolute treatment for Parkinson's disease, but we want to go into research. We want to diagnose these cases. And the current diagnostic criteria will only diagnose the clinically probable or possible Parkinson's disease, but not the prodromal Parkinson's disease. Also, it doesn't detect the preclinical Parkinson's disease. So for this, we have a myriad of biomarkers. There are radiological biomarkers, there are nuclear medicine, presynaptic and postsynaptic imaging, there are fluid biomarkers, CSF, blood and skin biopsy. I'm not talking about this, but these are the biomarkers, and all of these are currently in research level. We now know that the MIBG scan is now a part of the diagnostic criteria. So to summarize, the difference between the old criteria and the new criteria, we now know that postural instability is no more a core criteria. There are no negative features. For negative features, the previous criteria was only exclusion criteria, but the MDS criteria, we have the absolute exclusion and the red flag criteria. Then the positive features, there are supportive criteria. And ancillary tests previously, imaging was only to exclude the differential diagnosis, but now we have olfactory loss and cardiac MIBG, they are included as part of the diagnostic criteria. And in previously where we just made a diagnosis of definite PD, now we can make a diagnosis of clinically established or clinically probable PD. So all of these diagnostic criteria are based on either expert diagnosis or post-mortem biopsy-proven diagnosis. To conclude, Parkinson's disease till date is a clinical diagnosis. You don't need any tests. In fact, you don't need to do a SPECT scan to prove. But if there is a SPECT scan and it is showing that there is normal, then we doubt the diagnosis of Parkinson's disease. So tests for now remain ancillary and supportive only. And Parkinson's disease is a clinical diagnosis. And in order to excel in the diagnosis of Parkinson's disease, we need to practice. For every patient, MDS UPDRS score, and then we need to put in the MDS diagnostic criteria. Thank you.
So thank you, Priyanka, for a very lucid account of the current diagnostic criteria for Parkinson's. And I think from that we move on to our next speaker, who is another eminent speaker from Assam. Dr. Lakshya is a very good friend of mine and has a lot of achievements and accolades. And I think latest he has some award from American Academy Neurology. He has won some award from American Academy Neurology, which is the premier neurology society in the world. So I think probably this will need a session if I'm going to read all his achievements. So straight away I will go to Lakshya and to please deliver the talk for us. So Lakshya, please go ahead.
Okay, thank you, Neeraj, for your kind introduction. And thank you all the panelists and my colleagues and Dr. Divya for having me here. So I'll just start this here. Yeah. So Dr. Priyanka has nicely described about the diagnostic pitfalls and how we diagnose. Actually, we don't need anything to diagnose Parkinson. We need 2 ears, 2 eyes, and 2 hands. That is what James Parkinson told. And famously, it was mentioned by Bastian Bloom from Amsterdam. So, okay. So I'll go to the topic straight without wasting further time. So my job is to just give you a playbook for this is designed mainly for the physician. So my job is to give you the playbook for treating Parkinson's disease. As the formalities, this is my disclosure. And so I'll walk you through what is early Parkinson, when you need to start levodopa and other alternatives for Parkinson's disease. And just I'll jump on a couple of trials on levodopa and other dopamine agonist drugs like L-DOPA, LEAP, and PD-meds in brief. And I'll give you some algorithm how to treat early to advanced Parkinson's disease and how to manage motor fluctuation and dyskinesia. This is obviously it's a headache for the neurologist when this disease gets older. And there are some pulsal arrestor, means do's and don'ts. So this is the iceberg metaphor. The Priyanka has mentioned, and we all already have other speaker like Dr. Kostov who will be speaking on non-motor. So Parkinson disease iceberg, this is what we see, that is tremor, rigidity, and slowness of activity, falls, postural imbalance that we see. Now we don't see with the lower part of the iceberg. So this is one of the famous photograph from Anthony Lang and Dr. Kalia from Toronto. So they have described the natural history of the Parkinson disease from premotor or prodromal period to early and advanced phase. So I'm not going to touch the everything because already mentioned by the Dr. Priyanka. So if you take the natural history courses over a period of 20 years, then there are honeymoon period, initial 1 to 3 years, then followed by motor complication period, then you have resistance symptom, then cognitive decline period. So what are the armamentarium we have when we treat Parkinson's disease? We all know that we have various kind of, the number one drug is levodopa. This is the gold standard for Parkinson's disease. So we have various formulation of levodopa, instant release, extended release, then inhalational, then orally dissolving carbidopa levodopa, that is Parcopa, or intestinal gel. Then we have dopamine agonists, again, pramipexole, ropinirole, and rotigotine for those patients who cannot swallow or have problem with swallow. Pyrimidine is not widely available. Then apomorphine, it has changed the game in recent time. So I'll be speaking a bit on apomorphine later in the part of the talk. Then the NMDA receptor antagonist, that is amantadine, or when we use amantadine most, I'll be speaking on that. Then there are certain agents that enhances the levodopa action, that is COMT inhibitors and MAO inhibitors. So you should know as a physician or as a resident doctor that there are certain symptoms that, although it's the gold standard, that there are certain symptoms that is poorly responsive or non-responsive to levodopa. So there are 3 examples. Number 1 is the dystonia, that is flex post or twisted dystonic posture. Number 2 is the freezing, and number 3 is the loss of posterior. This doesn't respond or poorly respond to levodopa. So how to classify levodopa-related motor fluctuation in Parkinson's disease? It could be classified as a wearing off or a delayed on, and dose failure or no on random off or random off. So based on the different type of pathophysiology, like impaired gastric emptying, or intestinal absorption impairment, so you have delayed on, so like that. So when do you start levodopa? This is always the question, when you start the levodopa, because the earlier studies have shown that in culture, there is a generation of oxidative free radicals by dopamine. So there's a fear that it might induce apoptosis, or it might induce or accelerate the process of Parkinson. So this is a pragmatic decision frame. We have to treat the disability, not the diagnosis. Suppose I have diagnosed someone with Parkinson, but this patient is not giving me any disable symptom. Like, he is okay with the tremor, but he is not disabled. So I'm not going to start levodopa there. Unless it affects the patient's quality of life, then only we start with the levodopa. So the risk of dyskinesia, it relates to more than to disease duration. For example, more than 5 to 7 years, then you have a dyskinesia. Then you can start, even if you start levodopa, you can start without any fear of having accelerated progression, because I'll be talking about this trial that have not shown a solid evidence that it accelerates the progression. Then we should also avoid delaying levodopa therapy when it starts affecting your walk sphere, like a gait, walk, driving, etc. And what is the rule of thumb? Means if the patient age is more than 70 and the cognitive and psychosis risk is there and frailty is there, you should prefer levodopa. Then young patient, mild symptoms, then MAO inhibitor or dopamine agonist, but you have to watch out for impulse control disorder. Then if it is tremor predominant, levodopa consider anticholinergic rarely. I don't write anticholinergic because of a lot of side effect with the elderly patient. Then you have to also look at the comorbidity, like orthostatic hypotension and hallucinations, then excessive sleepiness. So in that case, you have to avoid dopamine agonist, even if patient is young. So these three, I have just, for the sake of brevity of time, I have included only 3 trials here. That is L-DOPA trial, which was steered by Stanley Fan, then LEAP trial, which was by Bastian Bloom, then the PDMS trial in Birmingham. So these trials are fairly recent trial. So in L-DOPA trial, they have not found that the levodopa increases the neurodegeneration, but in clinically, but in imaging like beta CIT, they have found that there's a excessive damage to the dopaminergic neurons. But this study was inconclusive. Then followed by LEAP trial is a delayed trial, are delayed versus early. And this trial have shown no difference in the UPDRS scale at the end of 80 weeks with the similar dyskinesia rate. So this trial, LEAP trial, has also shown no evidence in the levodopa that it is a disease modifying, because we don't have anything called disease modifying so far yet for Parkinson's disease. So if you start early, because the UPDRS, there is no change, so there is no worsening clinically. Then finally, from the Birmingham group, that is called PDMET trial. The PDMET trial is a large pragmatic trial, and it has shown that the levodopa is a strong default initial option for many patients. So what is the bottom line? So to start levodopa when needed for function, I have already mentioned. Then early PD algorithm rhythm, just I have mentioned it. You have to confirm the phenotype, as Dr. Priyanka has mentioned, whether it's a tremor dominant PDPD or it's a kinetic rigid or gait impact. So you have to find out the phenotype, then dose and counsel. When you start levodopa, you always start low and go slow. And you have to also be aware of the side effect of levodopa. Then non-pharmacological formulation, which will be taken care by Dr. Kaushik. And you have to choose the first line symptomatic agent. As a default, levodopa is the default, the gold standard, followed by MAO-B inhibitor for mild symptoms and dopa agonist for selected younger patient. Then in advanced stage, you have to recognize the changes. What are the triggers? When you have the triggers to act, that is wearing off, troublesome dyskinesia, early morning dyskinesia, or nocturnal off, dose failure, delayed on. These are the things that makes you to act in the advanced phase. So you have to document before you change the method. What is the pattern of the advanced problem, dyskinesia? What is the timing? What is the non-motor or contributor? And you have to keep a diary. So this is the stepwise medication algorithm for wearing off. You have to first step was optimize levodopa, then add an on extender like COM inhibitor or MAO-B, and now is the new is istadifilin, and the add or adjunct dopamine agonist in selected patient. Then the rescue and advanced option, that is apomorphine. Now we have a subcutaneous pen in India, so that is a good adjunct for treating freezing in the advanced Parkinson's disease, and followed by the device-related therapy, which will be next speaker will speak on the device therapy on Parkinson's disease. Then dyskinesia, you have to identify the phenotype and you have to choose the move. Then if it is chorea, you go for amantadine. And if it is diaphasic dyskinesia, you choose COMT or MAO-B. If it is off dystonia, then bedtime CR formulation or early AM levodopa or on extender. And in selected cases, botulinum toxin. So this is about the motor fluctuation, and the apomorphine. I have just already mentioned about the how to initiate apomorphine in case of troublesome freezing. And this is the summary of the medical management in Parkinson's disease. And you have to always be careful about the side effect, which I've already elaborated. And these are the pulse and ways. You have always ask your patient to keep a diary, and what is the most troublesome symptom. Then the OS study is serving levodopa despite functional impairment. That is, you have to think. And this is the homework for your patient. I always ask my patient to download certain apps like American Parkinson Disease Association symptom tracker app. This is very simplified. This is I have tried it myself just for example to show you. And you have a Stripe PDF, a Speech Bite that is for those patients with hypophonia. And now we also have a vibrotactile feedback shoes, and these also check your pattern, like around 48 gait pattern you can analyze and give a warning before you fall. So this is the important adjunct for non-pharmacological and you have to always and apart from these apps, fancy app, you can simply ask the patient to keep a motor diary in old school format. So I'll close with this. These are 3 takeaways from today's my talk. Then you have to start levodopa when the symptoms start affecting your patient, and you have to when you see any motor fluctuation in advanced Parkinson's disease, you have to optimize levodopa first and see the pattern, then add on the way I have mentioned in the previous slide. And the dyskinesia, it is pattern specific. So treat the pattern like a chorea, dystonia, etc. So I'll close it here because and it is important message that the Parkinson disease is the most fast progressing neurodegenerative disorder, but the hope is that we still have a medication for such a neurodegenerative disorder. If you compare with Alzheimer's disease, with the CBD, we don't have much armamentarium in those individuals. Thank you.
Thank you, Dr. Lakshya, for that wonderful presentation, which was crisp and it was very detailed as well as crisp at the same time. You have very clearly highlighted where exactly we could start levodopa, the predominant dictum that we have to start slow and go slow, and how where exactly you could still go with dopamine agonist, especially in young patients. So you have very well highlighted that. So moving on from the medical management to the surgical management of Parkinson's disease. So, Dr. Lakshya, could you unshare?
Should I share the slides?
Yeah, Ashish, if you could share your screen. So for the next talk on the Parkinson's disease surgical management, I would like to call upon Dr. Ashish Suswarkar. He's currently the consultant neurologist and movement disorder specialist at Bhailal Amin General Hospital, Vadodara. He's a very young and dynamic movement disorder specialist, and he has won the Young Investigator International Award at the 10th World Stroke Congress, and he has multiple national and international publications. Over to you, Ashish.
Madam, is it visible? The slides are visible?
Yeah, I think the patch is still there, but yeah, it's gone.
Okay, is it better?
Yeah, it's better.
Okay. So I thank IN President Secretary and our subsection movement disorder chair, Dr. Neeraj sir, and convener Dr. Divya madam for this wonderful program and giving me opportunity to present in this forum. So my topic is deep brain stimulation and surgical options. For the brevity of time, I will quickly delve into this topic in next 10 to 12 minutes. So we'll have a quick recap of PD symptoms when medications fail, and what are the surgical options we have, mechanism of DBS, how to select patients, surgical techniques, its programming, possible complications and advances. So first, we all know that there are cardinal motor features, non-motor features. We know there is a clinical staging by Hoen and Yar. We have to understand by the time of 4 to 6 years or 5 years, 40 to 50% of the patients, they start developing motor fluctuations, on-off phenomenon and dyskinesia. This is where, when the balance also is early stage impairment is developing, this is where I would suggest that the patient is in the window of deep brain stimulation. Again, as the disease progresses, that window is slightly better, but not when the patient is totally wheelchair or bedridden. I think that is not the point where the quality of life can be further improved. The drugs, we know levodopa is a gold standard, but wearing off dyskinesia is a problem. Psychosis at high doses, orthostasis high doses, that is a problem. Dopamine agonists, we know there are impulse control disorders, sleep attacks, lot of issues. MAO-B inhibitors give only modest benefits. There are multiple drug interactions also. COMT inhibitors, they give some extra duration with the levodopa, but again, high dyskinesia risk limits its use. So when should the treating physician refer to the movement disorder specialist for the surgical management? So there is a screening criteria. We call it as 5 to 1 screening criteria. If the patient requires 5 doses or more levodopa per day, his entire day in that, if the 2 hours is off time or 2 hours and more, that is the red flag. And the troublesome dyskinesia, that is taking away his quality of life, if it is 1 hour or more, that should be the screening criteria to explain and to suggest to the patient and relatives that DBS or surgical options are good for them. What are the options we have? Of course, the gold standard deep brain stimulation. It is reversible, it is adjustable, it is bilateral, and it is FDA approved, and it has got the robust evidence. What are the other options? We have stereotactic lesioning. It was done previously, and in resource limited settings, or when the financial issues are there, we can opt for stereotactic lesioning. The newer advances, there is something called as MRI guided focus ultrasound. It is a non-invasive 1 day procedure. It takes around 3 to 4 hours. It is usually done unilateral, but there is a recent approval for staged bilateral procedure also. But it is irreversible because we are ablating the areas. And emerging therapies are adenovirus vector associated dopamine synthesis neuron implantation, neuroprotective factors which can be implanted into striatum, but these are all futuristic ideas yet to have robust evidence. So DBS, what are the mechanisms? So I saw the textbook, there are multiple mechanisms given, but in one line, if I have to summarize it, wherever there is an overactivity of subthalamic nucleus and GPI, we want to kind of control that. So it is not the damaging lesion, it is rather an information lesion. So I give an example to my students and fellow colleagues that it is like an RTO, which is guiding who to stop, who to go, how many to go. So that signal information is guided by this deep brain stimulation. We have to understand that we have local field oscillations, that is the marker of PD, that is beta oscillations, and they correlate with bradykinesia and rigidity. And DBS acts to disrupt this motor synchrony, and that is how it gives the motor benefit. Now we have adaptive DBS also, local field potentials. They decide how is the potentials there, what is the clinical scenario there, and they themselves give the accurate and adequate stimulation, saving the battery and as per the patient's level of activity. What are the targets we have? We have subthalamic nucleus, where it is the maximum studied target. There we have maximum motor improvement in the dorsolateral subthalamic nucleus, that is the motor region. The nucleus size is around 150 to 300 millimeters cube. So it is a small nucleus. It has to be targeted with the highest precision. And because it is a small nucleus, it takes lower stimulation energy and battery taken is low. And most of the times it is the first choice in advanced Parkinson's disease. Next, we have GPI. It is a relatively bigger nucleus, around 400 millimeters cube. The better effect of this nucleus selection is it has got direct anti-dyskinetic effect. And whenever the dyskinesia is the major problem, we tend to select GPI as the preferred nucleus targets. And we all know it is a tremor relieving factor. Whenever we want to relieve the tremors, the WIM nucleus is the best target. But most of the times it is the STN and the GPI we use a lot. So who's the ideal candidate? We know that the patient has to be idiopathic Parkinson disease, fulfilling the UK brain back criteria. Patient should have motor fluctuations and wearing off. Patient should have robust, that is the very good UPDRS3 motor score improvement from baseline to after the levodopa introduction. If the patient is having disabling dyskinesia, as just now we discussed, the tremor, we know levodopa may not give the best tremor response. So medication resistant tremor. Age, there is no absolute criteria, but preferably less than 70. But in our institute, we have done patients who are more than 70 also. Disease criteria is preferably 5 years and more, because sometimes the atypical Parkinsonism, they in the initial phases like PSPP and all, they may behave like idiopathic PD and may not give the best DBS related response. and cognition has to be good. We cannot do it in progressed demented patients. An exclusion, as I discussed, atypical Parkinsonism, dementia and significant cognitive impairment, uncontrolled active psychosis and psychiatric disorder, no robust levodopa response, active suicidality, and other major comorbidities like cardiac and other systemic illnesses. And patient has to have, and the relative has to have, not to have magical expectation, but realistic expectation. We have to understand DBS is not the cure. It does not stop the neurodegenerative aspect of the underlying disease mechanism. It is to give the best symptom control and to provide the best quality of life, and also to reduce the ongoing medications and the IDRs of all those medications. Preoperative workup, it is very important that the neurologist and movement disorder specialist assesses the patient. Parallelly, our psychiatrist and psychologist colleagues, they do the cognitive assessment and other assessments also, like depression, anxiety, impulse control disorder assessments. So based on Atlas, we have the typical markings for these sites like STN and GPI. There are anatomical landmarks which we know. So patient initially has a stereotactic frame fixed under the local anesthesia, and with the scanning, there is an appropriate location marked. And during the surgery, during the intraoperative, we also check, along with anatomical demarcation, we also check physiological marking. When the patient's lead or the lead is placed in the subthalamic nucleus, we can see this irregular baseline firing pattern, and there is some auditory characteristic also to this. So that is how we decide that the lead is in the accurate position. And once the lead is placed, there is a tunneling made in the subcutaneous tissue from the neck, and the battery or the IPG is placed in the infraclavicular area in the chest, just like our cardiac pacemaker. So there is pre-op targeting, there is a frame fixation, there are newer frameless techniques also. We usually do awake surgery, but there are asleep surgeries also using anesthesia. Then the lead placement and the IPG or the pacemaker placements. Then there is a programming. Some people do the programming in the initial 3 to 5 days. Some people do it after 1 to 2 weeks. It is individual institute's protocol. So while programming, we have to see that how the medications are also adjusted, and there are no current related extra side effects. That is done by the trained movement disorder neurologist. So what is the outcome? If you see the UPDRS-3 or the motor score, there is almost, I always tell the students to remember 50%. There is almost 50% improvement in the off score. The dyskinesia duration and the severity goes down by 50 to 70%. The medication or the pill burden, that goes down almost 50 to 60%. And daily off time duration also goes down by 60 to 70%. Here we are seeing what are the benefits of the STN, GPI, and the VIM-DBS. We know that the STN is the most studied. All our parameters, tremor, JT, bradykinesia fluctuations are best controlled in STN. Of course, they are better controlled in GPI also. And for the best control of tremor alone, VIM nucleus, VIM thalamus is the best nucleus. We have to understand one thing. The DBS, the axial symptoms like dysarthria, cognition, or the gait, these are the issues which may not improve with the DBS, and sometimes there is a tendency that they may go little worse with DBS and the disease progression. So we have to counsel the patient about these realistic expectations. So here one video I would like to show. So here, whenever the current is adjusted, the tremors are disappearing. I hope the video is visible. And the patient's bradykinesia is better. He is able to turn the pages. If you see his bradykinesia, that is also better when the current is on, when the DBS is giving good current. But what are the complications we see? Of course, there are surgical complications. The chances of bleeding are less than 2%. Chances of infection is around 3 to 5%. Sometimes bleed can migrate with the disease progression as the CSF and the brain volume decreases. That change can also occur. Then stimulation induced, if the stimulation goes adjacent areas, dysarthria, facial paresthesia, ocular deviation can happen. Neuropsychiatric complications like worsening of apathy, hypomania can be noted. And as I said, axial features, sometimes they progress. They may or may not be DBS related, but could be related to disease progression. Now, again, I just want to highlight the therapeutic window. The 5 to 7 years is the good DBS window. That is when we have to offer this, not when the patient is bedbound or chairbound. That time we cannot give the good quality of life to the patient and, of course, to the patient's caregiver. So we have to understand that. There was a landmark trial, early STEM, that was the trial that showed that in first 5 years, 5 years is a good cutoff. Very early days, patients were offered DBS when they were 7 to 10 years and beyond. But now we know 5 years and beyond is a good time to offer DBS. There are advances, as I said. We can have adaptive DBS where the local field potentials are sensed by the electrode itself, and based on that, the current is given. Then there are directional leads. Previously, there was a circumferential current given, but now only in certain directions the current is given. There are now robot assisted and asleep DBS are also futuristic advancement. And there is also discussion going on where simultaneously subthalamic nucleus, or if the patient is having gate freezing, whether pedunculopontine nucleus, simultaneous double targets can be done. So the summary, DBS is a gold standard neuromodulation technique. Patient selection is very, very important. Levodopa response predicts the DBS outcome. STN gives best motor response and lowering the medications. GPI has got best antidyskinetic response and can be opted for older patients with cognitive issues. Neuropsychiatric screening is mandatory. We must act in the therapeutic window in the early 5 to 7 years period. We must assess suicidal risk, and newer techniques like adaptive DBS is also coming up, and our colleagues are also using it. We must know that DBS is a lifelong commitment. It is not like one-time surgery and then we have to forget. No, it is not. It is lifelong commitment. Thank you. I will just mention about MR-guided FUS. Here we have to understand that it is a OPD basis procedure. Patient is in MRI console. The multiple ultrasound currents, they are focused into the area selected. Let's say Wim thalamus nucleus as shown in here. And all this focus ultrasound, they give the thermal ablation in that area. And that is how they ablate the nucleus and they give the desired effect. Thank you. Thank you.
So thank you, Ashish, for a very nice discussion on the surgical therapies, and we will come to it more later, I think. And in the meantime, we have President of Movement Disorder Society of India, Dr. Achal sir, the President-elect now with us, and sir is also part of our IN. Sir has run this IN Movement Disorder subsection for many years. So,
Hello.
sir. Ila is also
hi
there.
everyone.
So
Movement disorder
Ila is
subsection for at least 6-7 years.
Hello.
So we had one
Oh,
more
Divya
talk.
also. Okay.
And, yes, sir. So all we have just caught hold of you, all of you. So we have one more talk left, and I think then we will have panel
Hello.
discussion, sir. We would request, sir, if you, Ila and Divya could be there, hang
Yes,
for
I'm
next
there.
few minutes. Sir. So we will have the next talk, and then we will have a panel discussion, and we will
Thank you.
request all your thoughts there along with Ila and Divya from AIMS Delhi. So please be there, sir, and Ila and
Yes,
Divya,
I'm
please
there.
be there. Okay. So Kaustubh is our next speaker, and he will be he is actually done fellowship under Pankaj, close friend of mine from Mumbai, and he is presently, I think, at Queen Square, and he will be talking now. Kaustubh, you are there, na? And he
Yes,
has
sir.
several achievements, and he's one of the future stars of movement disorder, and maybe present star, we can say. He's doing great work. So,
Thank you, sir.
Kaustubh, you please go ahead. Please
Thank
go
you,
ahead,
sir.
Kaustubh.
Yes, sir. Thank you, sir. Thank you so much for the kind introduction. Um, the slide is the slide visible, sir?
Yes, Kaustubh, please go ahead.
Okay, so first I would like to thank Neeraj sir and Divya madam for giving me this opportunity. This is a really great opportunity to present at an IN subsection. So today I'm going to talk about Parkinson's disease non-motor symptoms. So what people usually see are the motor symptoms, which are tremor, rigidity, akinesia or bradykinesia, and postural disturbances. But there is this hidden part of this huge iceberg, which are the non-motor symptoms, which usually are a little overlooked or not discussed very frequently as the motor symptoms are discussed. So now we are going to discuss a few things about these non-motor symptoms. So usually the non-motor symptoms may start years or even decades before the onset of motor diagnosis of Parkinson's disease. In the prodromal stage, hyposmia, sleep disturbances like RBDs, depression, constipation, and even fatigue, pain, and diplopia can develop in early stages. And then in mild stages or during motor diagnosis, we can have anxiety, hypophonia, dysphagia, and sleep disturbances like fragmented sleep and RBDs. They can present. And during late stages of Parkinson's, dementia, cognitive dysfunction, hallucinations, sexual dysfunction, incontinence, and orthostatic hypotension can present. So why these non-motor symptoms matter? So, because these non-motor symptoms, they precede motor symptoms, they can help with early diagnosis. And as we are discussing it now, that many disease modifying therapies for Parkinson's are under trial, they can serve as an early biomarker for these disease modifying therapies. Then they indicate that the pathology of the Parkinson's disease is more widespread than just the brainstem, or it involves limbic cortex. So it indicates that Parkinson's disease is a multi-system involvement disorder, and not just associated with brainstem dysfunction. Then these symptoms are associated with quality of life because they are more disabling than the motor symptoms. Specifically, depression, cognitive dysfunction, and autonomic dysfunction can be more disabling, and they can increase caregiver burden, or they can lead to institutionalization of these patients. Uh, Many non-motor symptoms are non-dopaminergic in origin, so they require separate targeted management. So if a physician or if a neurologist misses them, then they might treat the patient incompletely, and patient can have a really bad quality of life. And then these non-motor symptoms can lead to morbidity and mortality, including orthostatic hypotension can lead to falls, dysphagia can lead to aspiration, and cognitive dysfunction can lead to dependency later in life. So these are a direct cause of complications. So during prodromal stage, constipation is one of the most common non-motor symptoms. It is defined as less than 3 bowel movements per week or difficulty to pass stool due to autonomic dysfunction. And it is usually managed by a lifestyle modification with high fiber diet, that is 20 to 30 gram of fibers per day are advised. Then adequate hydration, which is more than 2 liters of water per day, and regular physical activity. Then we can try some osmotic laxatives like polyethylene glycol or lactulose. And if the patient doesn't respond to these, we can try stimulants or prokinetics, which include senna, bisacodyl, or fluperopide. So the next big thing is REM sleep behavior disorder. So what is REM sleep behavior disorder? So it usually happens because of loss of REM atonia, which leads to dream enactment behaviors. So patient has vivid dreams in which he acts, which are often violent. He keeps on kicking, punching, and shouting during the sleep. And this RBDs is a very strong predictor of synucleinopathy, and it may precede the PD diagnosis by decades. So how should manage it? So the first thing is we should look for safety of the patient as well as safety of the partner, whoever lies in the bed with him. So we should remove all the sharp objects from the bedside. We should add bed paddings, and if at all patient has history of falling from the bed, we should have a floor mattresses, and we should counsel partner for the safety. Melatonin is the first line and the safest choice for RBDs, but in many patients it does not show much efficacy. So clonazepam can be added at a low dose as a second line treatment. And alcohol and sleep deprivation should be avoided. And SSRIs and TCIs should be monitored because they worsen RBDs. Then depression. Depression is also one of the big symptoms during prodromal stage. It can be defined as a persistent low mood or anhedonia due to neurochemical dysfunction. Anhedonia is more prominent than sadness. That is, patient doesn't feel any sort of emotions in this phase. It may precede motor symptoms. It is often underdiagnosed and undertreated in many patients with Parkinson's disease, and it contributes significantly to poor quality of life. So how we can manage it? The first line management therapy for depression is SSRIs, which includes sertraline and escitalopram, and SNRIs, which is venlafaxine. Then we can use alternatives like bupropion and TCAs, like nortriptyline, and we can add dopamine agonist like pamipexole. However, they require a great caution before adding them, and we can always use cognitive behavioral therapy for it. Then hyposmia. Hyposmia is the one of the most common non-motor symptoms, and it is usually present in 90% or more than 90% of PD patients, and it is often unnoticed by the patient. It appears years before the motor symptoms, just like RBDs or constipation, and it is useful as an early biomarker for Parkinson's disease. But what are the downsides of not recognizing this thing, the hyposmia? So patients who have hyposmia cannot recognize gas leaks, or they cannot recognize the smell from spoiled food, and they can consume sort of spoiled food, and they cannot recognize the smell of smoke, and that's why it should be addressed properly. So right now there is no disease modifying therapy available for hyposmia, but we can do safety counseling, and we can because there is this high risk of undetected gas leaks and spoiled food consumption, and we can advise the patients and family to install smoke detectors and carbon monoxide alarms. Um, then anxiety. Anxiety may present at the early stages of Parkinson's disease. It is usually excessive fear or worry which is associated with Parkinson's related neurochemical changes. A patient may present with a generalized baseline anxiety, or may present with attacks or panic attacks which may be recurrent. And it often the anxiety often worsens significantly during off periods of levodopa, and social anxiety and phobias are very common in these patients. So what is the management of anxiety? So the non-pharmacological management includes cognitive behavioral therapy and mindfulness based interventions. And the pharmacological therapy, the first line pharmacological therapies includes SSRIs and SNRIs, and we can also use short-term benzodiazepines, but long-term benzodiazepines should be avoided. Uh, to treat anxiety properly, we should optimize the dopaminergic therapy, because it tends to worsen during off periods, and we can adjust the levodopa schedule to alleviate this. Uh, then again, apathy and fatigue are the most one of the most common non-motor symptoms. Apathy is reduced goal-directed behavior, and it can present as lack of motivation, emotional blunting, and fatigue is subjective lack of energy, which is not proportional to the activity of the patient. So patient becomes disproportionately tired to the activity or exertion that he has done. It often coexists, but these are two distinct symptoms. So how do we treat apathy? So apathy can be treated with dopamine agonists, but again, a great care should be taken while starting patients on dopamine agonists because of side effects, which can happen because of them. And if there is a cognitive overlap, that patient has a cognitive decline along with apathy and fatigue, rivastigmine can help. And for fatigue, first thing is optimize sleep quality. The patient should have a proper schedule of sleeping, that he should go to bed at particular time and wake up at particular time. And then we should need to treat the underlying depression. And even if the fatigue persists, then we can try modafinil in very selected cases. But in general, daily exercise and routine physical activity and structured daily routines help in fatigue and apathy. And then cognitive impairment. The decline in one or more cognitive domains, including attention, executive dysfunction, or visuospatial dysfunction, with or without functional impairment. So it can be seen in early Parkinson's disease or early mid stages. we can see that these patients they stumble during planning or site shifting, or they have a slow processing speed, or they might be inattentive toward the while conversations or doing their daily activities, and there might be some visual spatial difficulties which might emerge later. So how to manage this? The best pharmacological treatment for a cognitive impairment is rivastigmine, and it shows best evidence in the clinical trials. And donepezil can be used, however, it shows less robust evidence. Then cognitive training or rehabilitation can be given to these patients, and occupational therapy can be given. But it is most important that any anticholinergic drugs should be avoided in these patients, as they worsen the cognition in short term as well as in long term, even after they are stopped. So anticholinergics should be avoided, and the other thing is sedatives and benzodiazepines should be avoided if the patient has cognitive decline. Then the next non-motor symptoms is sialuria. Sialuria is defined as excessive drooling, but it can be there due to impaired swallowing of saliva or due to increased production. So, how it does affect the patient? So it can cause social embarrassment to patients, that why during in social situations they can have drooling and get embarrassed. Then there can be an increased risk of aspiration due to swallowing, and it can be managed with the first line is glycopyrrolate, which is a peripherally acting anticholinergic, and then we can add apratropium sublingual spray or sublingual atropine drops. But the gold standard for treating sialuria is botulinum toxin injection in parotid or submandibular glands, and the supportive treatment is speech therapy for swallowing and postural training. Um, the next and most important, one of the most important symptoms is urinary dysfunction. It can be defined as bladder storage symptoms due to autonomic dysfunction, that is detrusor overactivity, and it may present as urgency, frequency, or urge incontinence. The many patients also have nocturia, which is again a major cause of sleep disruption, which can lead to many other things, many other symptoms like excessive fatigue and cognitive decline. However, urinary retention in Parkinson's disease is very less common. It can be managed with behavioral therapies like bladder tanning and fluid restriction during night. But mirabegron gives better cognitive safety than oxybutynin or sulfasenil. So mirabegron is used most commonly nowadays. And in the resistant cases, intravesicular botulinum toxin injections to increase the volume of bladder or urological referrals can be done. Then sexual dysfunction. This is the one of the least spoken about symptoms or non-motor symptoms of Parkinson's. Specifically, males still do talk about it, but it is very less discussed in females. So it is impairment in sexual desire, arousal, or performance due to autonomic and dopaminergic dysfunction. So it can present as just as an erectile dysfunction in men, and can present as reduced libido in both sexes, and females can have arousal difficulties. So this may lead to relationship strain and may in fact lead to depression. So how to manage them? So in males, it can be managed with PDE5 inhibitors like sildenafil and tadalafil, and in females it can be treated with hormonal evaluation if indicated and testosterone replacement. Uh, then impulse control disorders. Impulse control disorders is inability to resist impulses which lead to harmful repetitive behaviors due to dopaminergic overstimulation. So this is because of most commonly seen because of dopaminergic agonist use, and it can present as pathological gambling, hypersexuality, compulsive shopping or eating, or compulsive internet use. Then it can present as funding, which is repetitive purposeless behavior or tasks, and it is primarily caused by dopamine agonists. So in male it presents as pathological gambling and hypersexuality, and in females it presents as a compulsive shopping and eating or and funding behaviors. So they have different patterns in males and females. Then how they should be handled or how they should be managed. The first step in management of impulse control disorders is to reduce or stop the dopamine agonists, because those are the most common causes of impulse control disorders. Then we can use behavioral therapies like cognitive behavioral therapy, family or caregiver involvement. And then in severe cases, a dopamine agonist should be stopped and psychiatric referral should be sought. Then psychosis. Psychosis is presence of hallucinations or delusions in late PD. Most commonly visual hallucinations are there, but many patients can present with paranoid delusions, passage or presence hallucinations, and often it can be because of the medications they are receiving. So so there is this algorithm of managing psychosis. First, anticholinergics should be reduced. Then amantadine, which can lead to psychosis, it should be reduced and stopped. Then dopamine agonist, and then if at all required, levodopa should be reduced. And an antipsychotic should be added to treat this psychosis, which include quetiapine and clozapine, which are the safest. And pimavanserin is the newer ideal antipsychotic used for PD patients. And if there is overlap with dementia, then rivastigmine could be added. Then during mid stages or later stages of PD, patients can develop orthostatic hypotension. So it is defined as fall in systolic blood pressure by 20 or diastolic blood pressure by more than 10 millimeters of mercury within 3 minutes of standing due to autonomic failure. Patients do present with dizziness, presyncope or syncope on standing from sitting position, and they have this typical pain, which is called as coat hanger pain, which involves the upper part of neck and upper part of shoulders. Uh, it can present as postprandial hypotension and can be worsened by dopaminergic medications. So, how it should be managed? So, first is non-pharmacological management. The first one is increase salt and fluid intake. Then patients are advised to use compression stockings and head up tilt sleeping. That is, patients are advised to sleep with their head up by 30 degrees. And then, if it is not controlled, then we can add a midodrine, fluorocortisone, droxidopa, or pyridostigmine. Then Parkinson's disease dementia. It usually presents after at least 1 year after established Parkinson's disease diagnosis, and it affects daily functioning of the patient. Visuospatial and executive dysfunction are the most common. However, visual hallucinations can also be seen. Then cognition may fluctuate, similar to that seen in a DLBD, and however, memory is less impaired. And the treatment includes rivastigmine, which is the best to treat Parkinson's related dementia or cognitive decline. And we can also use donepezil. However, we should avoid escalating dopamine because it may worsen psychosis. We should avoid anticholinergic drugs and avoid sedatives or antipsychotics. Uh, then patients may have advanced autonomic failure that includes severe constipation, bowel obstruction, urinary incontinence, postural hypotension, sleep fragmentation, and loss of sexual function. And it should be managed with a multidisciplinary team of neurologist, cardiologist, and urologist, along with gastroenterologist, and may involve a palliative physiologist or palliative care medicine guys. Then symptom-based treatments, it should follow individual symptom guidelines, which were included in the previous slides, and we should prioritize the quality of life and function. So to summarize, hyposmia, REM sleep behavior disorders, constipation, and depression can present as a prodrome in Parkinson's disease. Their diagnosis occurs mostly after 50 or 60% of dopamine neurons are lost, and it is most likely that these symptoms are because of non-dopaminergic cause. They do not improve with levodopa, so each and every symptom should have individual treatment. And then, because they are major determinants of quality of life, it is very important to treat them. So we should suspect them in each and every patient. We should recognize them, and we should treat them separately and promptly. So this was the review about the Parkinson's disease non-motor symptoms. Thank you so much.
Thank you, Dr. Kaustubh, for detailing the very important and not often treated non-motor symptoms. And you have clearly explained why it is very important for us to recognize as well as treat the non-motor symptoms. So it is almost as important as treating the motor symptoms for the well-being of a patient. So thank you for highlighting each of these points very clearly. So now we move on to the panel discussion. So, we have share the panelists.
Yes. So I think thank you, Divya. So we have a list of panelists already here, and we have some senior person, most senior Achal sir is there. Then Sujit boss is there as a panelist. So Divya, you want me to start with the question with Achal sir, and then we can
Yeah.
go to the
Sure. So
So
our panelists we can just introduce. We have Dr. Sujit
yes,
Ovalle,
yes.
Dr. Ajit Cherian is a professor at Sri Chitratirunal Institute for Medical Sciences and Technology, Dr. Balaji, who is the associate professor at Chengalpet Medical College, and Dr. Vaibhav Mathur, who is a consultant neurologist and movement disorder specialist, currently working at Narayana Multi-Speciality Hospital, Jaipur. So we
Okay.
welcome all of you to the panel discussion, and a special welcome to Dr. Sir for being here and being a part of this panel discussion. So I think Dr. Neeraj sir, you could start with the first question to Achal sir.
So I think that will be what Achal sir will be discussing. Will bridge the session done by the speakers and the questions which will be taken by the panelists. So sir, I would like to have your thoughts on the current status of treatment of Parkinson's disease in Indian context, sir, in India. So sir, please, we need your valuable thoughts on that.
Thank you, Dr. Neeraj. Thank you first to welcome me, although it's a Indian Academy Neurology session where I am already placed as a treasurer, though recently elected for Movement Disorder Society of India President-elect. Thank you so much for asking me to do something over here. So the thing is that Parkinson's disease, that's a degenerative disorder and a kind of disorder where we can do many things. There is lot of scope for improvement, lot of scope for treatment in these patients. So we heard about this from many of the speakers. So currently, if we talk of India, almost in India, there are more than 8 to 10 lakh patients of Parkinson's disease, according to one estimate. So those, of course, will require treatment. Still, even till today, the mainstay of therapy is levodopa carbidopa combination, which we keep on giving, and everyone does that. But nowadays, several new things have come up. New things means DBS, of course, which have been there for, again, many years in India as well. Although it was limited to major cities. If I say major cities means Delhi, Mumbai, Bangalore, Calcutta. Now it has gone to the tier 2 cities as well. Several of tier 2 cities are also doing. And not only that, now there is another development. Now we have high frequency ultrasound. And some of the therapies like TMS, we heard about that. So these things are coming up. And I am sure over years, many of the symptoms, when I say many of the symptoms, not only those 3-4 symptoms of Parkinson's disease, rather there are a number of non-motor symptoms. When taken care of, there is a lot of improvement in the patients. And the quality of life improves a lot. So that means now we are heading towards something which will take care of not only motor symptoms, rather non-motor symptoms as well. Several of measures be applied, not only drugs, there are other measures which may be applied. And that will definitely lead to a better quality of life in these patients of Parkinson's disease. So we are heading towards something which will have multi-specialty care. It will make the patients show the improvement in those patients. And also, some of the drugs have come for the management of non-motor symptoms. Not only those motor symptoms, some of the drugs have come in the market which we, when used, will give improvement in these patients. So what I think that today's topics were aptly selected and also delivered well by the speakers. And what we wanted to convey has been conveyed to the audience. Thank you so much.
Thank you, sir. Thank you. So I think one of the key points for what sir has told is that, of course, we are managing the symptoms, but then at the same time, we have to focus on the quality of life, because it is how much the patient gains in the quality of life that is important. So I think with that thought, we can move further and we can take Divya, you can proceed with Sujit boss, and boss is already there. Yeah, please go ahead.
Okay. So I think the first question I would start with Dr. Balaji. So you're there?
Yes, yes, I'm here. I'm here.
So
Balaji, yeah,
welcome to the
Balaji.
panel.
Hi, hi, hi.
Welcome, sir. So yeah, I would start with the first question to you. That is, in your practice, what are the challenges often faced by the general physician? Because we are clearly addressing the general physician and general neurologists, as well as the junior people who actually have a junior as well as senior consultants who have multiple challenges which are often faced by them in the identification and management of Parkinson's disease on a day-to-day basis. So what are those challenges, and how would you like to address them?
Yeah, good evening, Divya, and good evening, others. I think Priyanka rightly started the session with clearly telling that Parkinson's disease is a clinical diagnosis. I think that's the message which we should drive to our junior colleagues, and we should make those. I think I'm audible.
Yes, sir.
Yeah. So I think we should make them confident, especially the practitioners, that the Parkinson's disease diagnosis is largely clinical, and the certain non-specific symptoms like the vague shoulder pain, fatigue, sleep disturbances, and other things, I think they should be looked into more in detail in the context of Parkinson's disease for an early diagnosis. I think early diagnosis depends on capitalizing those non-specific symptoms and looking towards some clinical signs of Parkinson's disease. And again, the other speaker mentioned about the non-motor symptoms. I think the constipation, the RBDs, the depression, anxiety, I think those should be again properly seen and further examined in the context of Parkinson's disease. And there is also another side of it. So people come with an overdiagnosis of Parkinson's disease. People with long-standing tremors and other things come with a Google and come with a fear of developing a Parkinson's disease. I think it's also the other side is important, making it clear that if there is no slowness, there is no Parkinson's disease. So though there are other clinical signs, the bradycardia, rigidity, tremors, and other things, it is the bradykinesia that's the essential part. The diagnosis of Parkinson's disease revolves around this bradykinesia. Is a message which I think to be driven very hard. And with regards to management, I think it's all about the managing the side effects and knowing the drug properly, and differentiating between the effects as well as the side effects, which can be managed by decreasing or increasing the drugs, and spacing, especially I think spacing the levodopa drug apart from the meals and apart from the protein intake is an essential part, I believe. Yes, Divya.
Yeah. Thank you, sir.
I think that the very good message from Balaji, because what actually this Priyanka also highlighted, the clinician judgment is very important in diagnosis, and recent studies they have shown that almost the diagnosis made by expert, like Priyanka highlighted, if somebody who has seen 300, 400 patient is as good as when you apply the criteria. So that is something which we have to. So somebody who has a doubt, probably sending it over to somebody who is close and nearby and has a expertise in PD, that very much confirms the diagnosis. Yeah, Divya, please go ahead.
Yeah. So I would like to ask Dr. Ajit. So as a physician or any established person, it is very easy to make a diagnosis of Parkinson's disease. So as a physician or a general neurologist, is it mandatory to refer every patient of Parkinson's disease to a movement disorder specialist?
Thank you, Dr. Divya. I think this disease is best addressed by a movement disorder specialist. The reason is because, unlike in, like, say, for the matter of fact, in stroke, where you have one size fits all, you have a standard care therapy of aspirin 150 or statin 10. It's not like that as far as Parkinson's disease is concerned. The treatment is not the same in all. So, for example, if you have a young onset PD, we would start with the dopa agonist, D2 agonist, whereas if it's an elderly, we start with the levodopa carbidopa combination. So these kind of treatment decisions, it's best left to a consultant. And when this monotherapy effect wanes off, the time to give an add-on and what will be the best add-on, I think it is best decided by a person who is expert in the field rather than by a physician. And at the physician level, as an MD general medicine level, your exposure to these drugs and how to apply these drugs is very limited. And one should have this idea of when to go for the intervention. That is what, like DBS, what I mean. So there is a phase after 4 or 5 years when that as Dr. Ashish has already pointed out, when the motor fluctuation starts happening and the dyskinesia and the off period goes and the tablets goes beyond 5. So that's the ideal time. So these are best handled by a consultant. And there are also multiple non-motor symptoms, as Kaustubh has clearly pointed out. That also needs to be addressed. It's not just the motor symptoms alone. And there are specific entities like nocturnal akinesia, where you might use a controlled release preparation, or an early morning food dystonia, where you may have an immediately acting preparation, or a crushed tablet with lime juice, like for the early morning food dystonia, and how to manage peak dosage. These are all best addressed by a consultant or an expert in the field, rather than to be left with a physician who will have absolutely no clue as to how to manage this case. So I think Parkinson's disease is best addressed by movement disorder specialists.
Yeah, thank you, sir. I think as first contact providers, physicians as well as general neurologists do have a role, especially in counseling, as well as adequately educating people and persons when they should be taken up for surgery, or there is even an option that is available. Most of our patients are not even aware that such an option is available. So I think the physicians have a very key role in that aspect, and I think they definitely have a role in rightly referring them to a movement disorder specialist.
I think, and another thing which I would like to bring, Ajit very nicely said, that a patient must see a movement disorder specialist.
Correct.
But at the same time, it may be difficult for him to repeatedly visit a movement disorder specialist. So first visit, he can make a plan, and then the local physician can keep a follow-up for say few months, and then again intermittently he can go. So that will be an ideal situation where, because movement disorder specialist may not be available at every places in India, apart from the metros and some major cities. But you rightly said that he should initially be seen by a movement disorder specialist who can make a plan that this is the
Right.
plan. And then the physician can definitely be very important person to really carry out that plan. So yes, excellent said,
Yeah.
Ajit. Yeah, please go ahead.
Thank you, sir. Dr. Sujit, sir, my next question is to you. That is, there are multiple advanced treatments and surgical options which are available for Parkinson's disease. So, what are the challenges that you face when a patient is referred to you for a surgical option? And what are the surgical options which are available? It has already been described, but would you like to highlight some of the surgical options and the challenges that you face with regard to them?
Thanks, Divya and Neeraj, for giving me this opportunity. Many patients, when they are referred to DBS, they come with huge hope because they are going to spend so much money. They think this is the final answer. That is the thing you have to convey. This is not the final answer. This is just another add-on therapy which may improve the quality of life. That thing should be very specifically mentioned. It should be explained to the patient as well as the relatives. Otherwise, they will go into depression. After doing this, there is no much benefit. That is the usual complaint. Immediately they will tell you. So initially itself, you should counsel the patient regarding the outcome that you are going to get. Then regarding the patient selection, apart from the economic factors, you should consider the age. Generally, in my experience, the younger the age, better the results. Below 70 is the best. But I've done cases in up to 76 when there are no other comorbidities. You can select because you can definitely improve the quality of life with DBS because the patient may be dependent on a relative for going to the toilet. So if you can make him walk better, that itself will make his quality of life much better. Then, as you said, you should avoid patients with frank dementia and frank psychosis, uncontrolled psychosis. These patients should be avoided and always look for any Parkinson plus syndromes because whenever you are selecting patients early in the disease, after 4 years, you may sometimes do DBS in some of the Parkinson plus, then that should be clearly looked into, especially looking for the eye movement, axial rigidity. All these should be specifically looked for, and MRI should be taken and look for the brain stem atrophy that can be seen in PSP. These are the things. Then regarding the criteria, the clinical criteria of at least 2 hours of dyskinesia, such things are also useful, and 30% improvement in the levodopa response. I generally do it because only patients who is having levodopa response will respond to DBS. That is very important. So more than 4 years of age, at least 2 hours of periods, and at least 1 hour of dyskinesia, and not extremes of age, you can go in for DBS. That is my take on that.
Yeah. Thank you, sir, for elaborately telling us what is the challenge that we face on a day-to-day basis when we advise patients for DBS. Next, I would like to ask Dr. Vaibhav Mathur, what is the role of treatments other than deep brain stimulation? Like there are multiple people who come to us seeing certain videos of certain injections being given. So we have seen apomorphine or MRGFUS. So what is the role of other advanced therapies other than deep brain stimulation?
So very good evening to all of you. Am I audible?
Yeah.
Yes, Vaibhav,
Yeah.
please go ahead.
Yes, sir. So I think, yes, it's a very interesting question, and the scenario is pretty similar to what Madam just said. So people see a lot of videos regarding what all therapies that are available. So first of all, I'll talk about apomorphine. Apomorphine is, we all know it's a dopamine agonist, D1 and D2 receptor agonist, and is an injectable form of dopamine, which is useful in certain selected patients. So it is available in two forms. One is an immediate release form and one is a continuous pump form. An immediate release form can be useful as a rescue therapy. So people who have got sudden unpredictable offs, there these apomorphine pumps which are readily available now can be used for patients where we can have benefits in maybe 5 or 10 minutes, which is a little quicker as compared to the oral tablets. Secondly, the continuous pump form of apomorphine that can actually be useful in selected patients. So maybe we have a patient who is presently not very suitable for a DBS or is not mentally ready for it, or maybe we want to buy some time for a surgical therapy option. Those patients can be taken if they have a good dopamine response. And secondly, patients who are atypical Parkinsonism, not good candidates, but still dopa responsive, can be a candidate of apomorphine pump, where we ask the patients to use a continuous supplementation form and get an SC injection which continuously delivers the drug. Obviously, there are limitations and disadvantages in form of pump blocks, very commonly a lot of nodule issues and hallucinations on and off. So those who have psychotic issues in the past are not very good candidates for sure. Secondly, MRGFUS, I think very well explained already by my fellow speaker, Dr. Ashish, where he told us about it's a lesioning therapy. So a lesioning therapy which focuses on various areas of the brain like VIM thalamus or maybe GPI for improvement in the symptoms of the patient. But so now the candidate selection for MRGFUS is also very selected. For example, unilateral symptoms can be very well be treated with MRGFUS as a lesioning therapy, where we ask the patients to have a non-invasive form, a helmet form, which is wore over the head, and very selectively we target the areas, the thermal regulation, and where we have to burn those areas in a very targeted and a very controlled form, where we can have good improvements in the symptoms unilaterally. So tremor dominant forms can be targeted with VIM thalamus, and even dyskinesias can be well controlled with GPI. But MRGFUS said to be non-invasive, and but obviously is very invasive in the form that we are actually burning the tissue with a non-reversible option that is being used. But yes, for selected candidates, apomorphine pump and MRGFUS can be a good therapy.
So I think very well said, Vaibhav. Only thing is that you very rightly said that for tremor dominant asymmetrical, it can be helpful. But uh, the fact that it's a neurodegenerative disorder and it is definitely inevitable that it will definitely progress further. So, so that is something which probably we will have to keep in our mind. And the patients also need to be explained before he agrees to go for that, because later on he might be having issues and then some other therapies might have to be supplemented, whether medical or surgical. But very rightly said. ठीक है, Divya, please, Divya.
Yeah. Dr. Ila, I would like to ask you, like we know Parkinson's disease, a lot of problems have issues with gait and falls, especially in the later stages. So how can we improve gait, and what can we do to prevent falls in patients who have these symptoms in Parkinson's disease?
Thank you. Thank you, Dr. Divya, for raising this important concern. And I would like to thank the IN Movement Disorder subsection for this opportunity. So, as we have seen in the previous sections, though Parkinson disease is a progressive neurodegenerative disorder, we do have very effective treatments for treating Parkinson's disease. So, we have seen that levodopa is very effective, and the first step in patients who have falls and difficulty in walking, gait disorders, is to optimize levodopa. Make sure that the patient is taking it away from food and high protein containing diet, and these sort of things have to be looked into first. Then sometimes patients may need, with progressing disease, patients may need a higher doses of levodopa, which can be optimized by a movement disorders expert, as Dr. Ajit was just clarifying. And we also, some studies have suggested that medications like amantadine have effect on improving gait. So these are the medical therapy that we can do. Sometimes if the gait is very levodopa responsive, and in between during the off periods the patient is having freezing, as our previous speakers have discussed, apomorphine pump, or in very selected cases deep brain stimulation also can help, though we should remember that DBS can occasionally worsen gait in patients who have significant gait dysfunction. There is a select group of patients in whom DBS also has a role. Now, these are the medical managements that we commonly do. Then we come to the non-pharmacological management and looking at the cause of falls. Like, for example, there may be a subgroup of patients in whom there is significant autonomic dysfunction and fall in blood pressure. So we need to identify why the patient is falling. And if there is significant fall, then for management of autonomic dysfunction, also we have non-pharmacological measures like adequate fluid intake, not getting up suddenly, wearing abdominal binders. So these things can be addressed as well. And we also have some medications like midodrine and droxidopa, which can help in improving the blood pressure. Now, coming to safety measures, like inside the house, sometimes when there are elderly people, we may need to make modifications, like you can. The highest risk of fall is usually in the bathrooms and the wet floors. So it is always a good idea to have grab bars so that the people don't fall, elderly people. And it's always a good advice which you can give patients who have a little bit of impaired postural stability. Whenever you find that the pull test is even slightly affected, you start advising patients not to take bath in the standing position. Always try to use a small stool or a bath chair, so that especially when the eyes are closed, when they are taking a bath and the floor is wet, there is a very high risk of fall. And if the person is staying alone at home, or even with relatives, it's always a good idea not to keep the bathroom door closed when they are using the bathroom, so that even if they fall, someone can come and rescue them. And other things in home modification include, like, for example, when there is a at night when the patients get up to go to the washroom, so it is always preferable to have a well lit corridor that is leading from the bedroom to the bathroom. And these days we do have sensors, lights which have sensor based working. And when the patient gets up and walks, rather than having the corridor dark, the lights will automatically light up so that the path is clearly visible. And we should always make sure that the rugs, that they don't have any tangles so that they don't fall. So these sort of measures, even though they may appear to be very simple, and sometimes it may appear like to be beyond the scope of a neurologist to be giving this advice, they are very important for the patient's family to know this. And if it is possible, if you have a OPD attendant or someone, you can train them so that you may not have the time to discuss so much with the patient. You can either have pamphlets or train some people in your OPD who can educate the family and the caregivers as to these non-pharmacological measures as well.
Thank you, Ila, for excellent account on this. And one of the very easy things, as I think you also mentioned, is the decluttering. Like there are now the houses are becoming smaller and smaller, and all the furnitures and everything, and that is the place. So mostly, as you have said, the kitchen and the washroom are the two places which are very frequently the falls are happening, and of course the cluttering, a cluttered environment. So these are really small tips which you have said that must be shared.
And also, whenever you have new onset falls, you should always look for infection, especially urinary tract infection, new onset freezing. Also, you can have urinary tract infection or respiratory infection. And then suddenly, the person who was not falling starts falling, or who was not having freezing suddenly has a worsening of freezing. So, once you address that, they go back to the baseline where the falls and freezing have reduced. So, that new onset and a sudden worsening has to be taken care of.
Especially a role of hyponatremia and hyperammonemia. Constipation
Yes.
induced hyperammonemia and hyponatremia. Very
Yes. So
important.
correct. Medical causes has to be ruled out, whether it is PD related or it is systemic, and before we go for all, and of course, all other things must be done at the same time, as you rightly said. Okay. Next question we can take.
Yeah. Dr. Balaji, what is the role of exercise and diet in Parkinson's disease?
Yeah, I think we don't have a proven neuroprotective for Parkinson's disease. But I think many studies have shown that exercise, they actually reduce or slow the progression of disease. I think exercise can be either aerobic, or it could be addressed towards the balance training or strength training. I think it should be done in all these domains. And nowadays, a lot of novel exercises like music therapy and so on and so forth are being practiced in many places. So the recommended the exercise schedule is about 2.5 hours a week. That's what studies say, to bring an optimal improvement in the symptoms of Parkinson's disease, especially on a group basis. That will be very helpful. And with respect to the diet, I think Mediterranean diet is the most preferred one. I think certain things regarding diet is that it should be very conscious about the constipation producing diet. I think we should take a lot of fibers, and hydration is again very important in the wake of some people developing orthostatic issues. And I think with respect to protein, I think we should be careful that levodopa absorption can be affected by high protein. So it's not a bad idea to reserve proteins unusually during the night time, and always anti-inflammatory foods like berries and other food rich in antioxidants are being advised. So I think that's what I want to say about diet and exercise in Parkinson's.
Yeah.
To add to that, the cycling is said to increase the dopamine release, and the effect is said to last
Correct.
longer.
Yeah. Like insulin sensitivity, dopamine sensitivity also could be increased by exercise. Yeah. You want to say cycling, sir? Cycling is very specific.
Yeah. So maybe static cycling may be a better option. Right?
Yeah, static cycling or the orbit, because that cycling type of movement in lower limb is said to increase the dopamine release, and it is said that the effect lasts a few weeks, not just that same day.
Yeah,
Thank
can I jump in, Divya, just for
Yeah, sure. Sure, sir.
Yeah, thanks, Neeraj. I just wanted to put a word on the exercise here. Most of the work done in exercise in Parkinson's is done by Bas Bloem in Amsterdam, Netherlands. So what he suggests that we should have exercise snacks. Means you break your exercise, 30 minutes exercise into small chunks, so that you do half an hour, but it should be broken into several parts. So that is one. And second, he advised that the exercise should be done when the patient is in on stage, not so whenever I counsel my patient, I said, whenever you feel good, no, whenever you are on, then only you go for exercise. It is not that early morning you are off, you have to go for a walk, or you have to take your dog walk. It's not like that. Whenever you on, take your dog, then walk, like that. So yeah.
Super. That's a super point. Actually, that's a very, very excellent point, because you have patient has to be on to really gain something out of the exercise.
Yeah.
Great point, Lakshya.
Thank you.
So, Dr. Ajit, this has been highlighted, but just to throw some light again, what are the causes of Parkinsonism other than Parkinson's disease, and when should one suspect that it is not Parkinson's disease and something else, whether it's atypical or second?
Thank you. Whenever you have a short duration history, like whether few days or weeks, when you have a rapid progression, the disease progressing to disability within weeks or months, or early falls, cognition getting affected early in the disease, or visual hallucination or a fluctuating course. So these are the key things one should keep in mind historically, that this is unlikely to be Parkinson's disease, or it could be a secondary Parkinsonism or an atypical Parkinsonism. Now, for atypical Parkinsonism, the points that have been highlighted are early postural instability characterized by falls within 1 year of the disease, or if you have ataxia, lymphataxia, erectile dysfunction even before the onset of bradykinesia, or urinary symptoms very early in the course of the disease, postural giddiness, apraxia of one limb, or fluctuating course or vivid visual hallucination. When you have the next following features, you should think of some other secondary causes of Parkinson's, especially if you have a very symmetric bradykinesia, or orofacial dyskinesia, or craniocervical axial dystonia, or a lingual dystonia, especially drug-induced or D2 blocker-induced, especially if you have retrocordis or torticollis or opistotonic posturing. And if you have lower limb bradykinesia more than upper limb affliction, you should think of vascular Parkinsonism, or you should consider normal pressure hydrocephalus. Early post instability, you should always think in terms of a tactile based lesion, especially tactile based gliomas or midline teratomas, or any of the other lesions has to be thought. If you have severe cognitive affliction and a very rapid progression, always think of some infection, especially infections like dengue, chikungunya, or tuberculosis granulomatous involvement, or in case of retroviral disease, always think in terms of a cryptococcal neoformans. Immune mediated is another thing one should keep in mind. They tend to have short duration. We have published cases. Symmetric CSF IgG index will be very much elevated, and neuronal markers, especially the anti-re, anti-mark, and sometimes you may not have any neuronal markers. In these cases also, the high index of suspicion, you should think in terms of a immunomodulatory therapy, because that is quite rewarding and patients become near back to normal. So these are all treatable cases. Now, other toxin-induced needle marks in the forearm should be seeked into, because contaminated heroin and cocaine can be a cause. Endocrine causes like severe hypothyroidism and hypocortisolism, And one should never forget metabolic causes like hypercalcemia and hyperammonemia. So these are the things one should always keep in mind to rule out either a secondary Parkinson's or a typical Parkinson's. Thank you.
Thank you, sir, for elucidating all the secondary and atypical causes and where one should keep that red flags are appearing. So, Dr. Weber, we have already talked about non-motor symptoms, and we know that psychosis in Parkinson's disease is a huge cause of a caregiver burden. So, how should one manage psychosis in Parkinson's disease? And you could just highlight on that.
Yes, so very, very true. So Parkinson's with psychosis are actually increased caregiver burden issue, basically. So in Parkinson's, the reason of psychosis, one is an advanced disease, and secondly is the dopaminergic therapy. With advanced disease, the common type of hallucinations that we see are visual hallucinations. People have illusions and then paranoid delusions. These are three common things that we see in PD psychosis. Now, coming to the treatment, we have to, in most cases, we assess and prescribe. Here, you have assess and de-prescribe. So we have to clean up the prescription when you see a patient of psychosis. Basically, what is the assessment about? The most common things that we need to see are the secondary causes of psychosis. So we in our fellowship, we were very conveniently taught about this SCID skid. S for sleep, if the patient is not sleeping well. C for constipation, I for infections, and D for drugs and dyselectrolytemia. So these are very common secondary causes that I think we should assess in our history as well as with our investigations. So insomnia has to be addressed. Infections, very commonly UTIs, which as we know in elderly and Parkinson as well, fever is not a very common symptom. So we have to be very prudent about checking for routine urine or culture or something like that. And chest infections, skin infections, all kind of infections are common causative factors. Drugs, so there are common drugs that you can find in a prescription like anticholinergics, so THP, then atypical antipsychotics, which might have been prescribed for control of the psychosis, which include risperidone, olanzapine, aripiprazole, and others. So those drugs need to be removed. As we know, they are dopamine blockers, so they might worsen Parkinson's as such. And then dyselectrolytemia involving hyponatremia and maybe hyperammonemia. These are common things that as secondary causes we need to rule out. Coming to medications, as we see that there is no other medication which is causing it, then coming to our medications, the second drug after THP that you need to remove is amantadine. Then maybe dopamine agonists can also cause like pramipexole and ropinirole. And then at the end, we might come down to reducing levodopa as such. Uh, Medications for psychosis which are available and are being used commonly are pimavanserin, which was very which is very commonly used for maintenance therapy. So pimavanserin is not a very fast-acting drug. It is a slow-acting drug which needs to be taken with quetiapine in the initial months or initial weeks, and then we can use it as a monotherapy. Quetiapine, as I already said, is one of the most common agents that we use in for our practical purposes. And low doses of quetiapine can be even good enough for both sleep as well as hallucination control in Parkinson's disease. And the third drug, then, in refractory cases, would be a clozapine. So these are the three medications that we can use. But yes, most cases are generally treated with ruling out the secondary causes and possibly the medication-induced psychosis.
Thank you, Vaibhav, for excellently explaining the most important or one of the stressful symptoms of Parkinson's disease. Now, coming to Dr. Sujit, what is the role of therapies like acupuncture or mixopathies where people combine Ayurveda, Siddha, Unani or whatsoever with the current treatments that we give, or the stems and also the stem cell therapy, which is on and off coming in the discussions always from the patient side?
Regarding the CAM, as one of the speakers has said, Parkinsonism was identified and treated in ancient India and ancient Arabic literature, Chinese literature. They have used several drugs which are found to be useful even now because so many countries have like alternative medicine. So what we found are they use anticholinergic, there are drugs that reduces the progression of the disease, and 7 to 9% of levodopa in mecunaperients. So all this, if you take into consideration, and in 800 BC, there was a book on Parkinsonism itself in India. So ancient literature has something good in them, and which are even now useful, because you will see many patients of you taking levodopa along with mecuna powder, and they said they have less of dyskinesia and the effect lasts longer. So you can take the advice of these people also, because they have something in it. That's why people are going in for it. That is about the alternative. Actually, I was asked to speak on the subject in Hong Kong International Movement Disorder camps. I was addressing the Eastern, and there was one person for Western literature, because everybody has their ancient medicine which were useful. So that is it. And regarding the stem cell therapy, I also read in the newspapers that Japan has approved it. Probably if they can identify the dopamine specific stem cells, it will be the future of Parkinson. Probably all the movement disorder specialists will lose their job if it comes, the dopamine cells are identified and they can transduce it. I don't know much about it. Maybe in future it may be a prominent treatment option. But indigenous medicines have something good in it. That's quite important. That's why so many people are going to indigenous medicine along with modern medicine.
But it may be difficult to combine both of them. So it would be always better to tell the physician or the movement disorder specialist that you are on an alternative drug, especially. That I think is very important. Yeah, but even if you tell that you don't take it, they will not agree. Some people are fond of alternative medicine. It is very common in India as well as in China. China, even the government is promoting that along with the modern medicine, because they feel there is something good in it. That's why it is being promoted by the government itself. Here, even though the government is not, people will go for alternative medicine along with this. Some people are bold enough to tell you, some may not tell you. Yeah, sometimes you will see people with severe dyskinesia are giving only small quantity. If you ask them specifically, they will say, we are taking some powder along with that. Because if you take 1 spoon of powder, it is almost equivalent to half tablet of levodopa. When you calculate about 5 to 7 percentage. So they will produce side effects. Yeah. Thank you, sir. So coming to the last question, Dr. Divya, what are the precautions before an elective or an emergency surgical procedure? Because we have many Parkinson's disease patients going on for elective surgery, whether it's cataract or any other surgical procedure. So what are the general precautions that you would advise patients who are having PD before a surgery?
Thank you, ma'am. Actually, very important question, because many times we have seen patients who are actually stable on medication later after a surgery comes up with very much significant symptoms. So this usually happens because the treating team stops the medication abruptly. The message is that you should not stop the medication before surgery. So stick to the schedule of the medication and plan the surgery and take the medication even with a sip of water in the morning. So for elective surgery, always we can plan that the surgery is done in the morning hours so that we don't miss the medication. And as soon as the surgery is over, let's start the medication. If the patient is not able to take it orally, we can have other alternative options. We can have a Ryle's tube insertion and we can give the medication, and we can have apomorphine injections available. And sometimes we can use even a patch if available. And one thing we have to remember is that if you are using an nasogastric tube, do not give the continuous release preparation. You cannot crush it and give it to the tube. And another thing is that we have to always avoid using dopamine blocking agent drug, particularly when you are using antiemetics and all. Prefer to use a non-dopamine blocking drug for the as an antiemetic agent. So the same applies to the emergency surgeries also, as far as we should not stop the medication and we should take it before the surgery with a sip of water if it is not contraindicated. Usually it can be done.
Thank you, Divya. So I think with that, we come to the end of the panel discussion, and we'll just take a few questions that are there in the chat box. So one of the first questions is...
All speakers and panelists are there.
Yeah, anybody can answer. So one of the first questions is, are TMS can be considered as an adjunct in PD in centers. The question is, what is the current evidence and practical experience of using TMS in Parkinson's disease? So would anybody like to take that?
I think Lakshya has answered it. I think Lakshya, you're there?
Yeah.
So you can take. I think you've already answered it, but you can
I
again
already
repeat
answered it.
for the
Means,
sake of.
just because of the sake of time. So basically,
Yeah.
it's still not a standard of care for Parkinson disease, but yes, you can opt for it only for the motor syndrome like freezing and depression. So we have the modest evidence on freezing and the depression, and that too SMA and primary motor cortex stimulation. Yeah, and again it depends on the high frequency and low frequency stimulation. But as of now, means because we are now a lot of physician among with us, so I don't want to give a message that the wrong message that the RTMS is we are doing RTMS. No, RTMS should be only selected and should be a shared decision making between the treating neurologist and the patient only for some specific reason. Yeah, thank
The
you.
effects are not very long lasting, so
Yeah, short. Yeah.
that's the major issue with it.
Found to improve the mood of the patient. So in depression, if there's an underlying depression, it may make them euthymic. So that is one advantage of RTMS. But these effects are not long standing because over a period of 3 to 4 weeks, the effect can wear off.
And of course, then if you have the primary treatment available which are working, then I don't think there is any point in going to RTMS unless until you find that for any particular symptoms which is refractory to the available treatment. Because there is no as such recommendation. One thing what Lakshya also has written and Ajit said, depression. So mood is something which already they have shown that can be helped by RTMS. So that in PD definitely might be helpful if your drugs are not working. Only after that.
Dr. Kaustubh, the next question is, kindly comment about additional benefits with pimavanserin in PD dementia. Should it be limited only for psychosis or does it help cognitive impairment? Kaustubh, would you like to take that? Okay.
Kaustubh is not there. Kaustubh? I think he's there. I think Kaustubh, you're there?
Okay.
I think
Yeah, so quickly.
So Divya,
yeah, I will add
anyone?
that is generally it is not for dementia, it is recommended for psychosis. Pimavanserin is the only FDA approved medication for PD and for psychosis in Parkinson's disease. We do give quetiapine and clozapine because they have a faster effect. Pimavanserin takes at least 4 to 6 weeks to act, but it is for the psychosis, and just patients with dementia may not really benefit. And it can be used in psychosis with AD or FTD as well. So it is basically as an antipsychotic rather than a drug for dementia. So what about
practically sometimes some patients do not receive this drug very well because side effects sometimes, especially when you start it immediately. Pimavanserin, I found it sometimes people do not tolerate that drug. It's not tolerated by like quetiapine.
Yes. So I think whatever benefit, Divya, as you said rightly, if there is some studies have shown a benefit in cognition, but that can be because of the psychosis part being taken care of. So
Also,
you can go to.
effect is weaker
Yes,
compared
Lakshya.
yeah,
please. Okay, Azir, you carry on.
The effect is actually weaker compared to the quetiapine and the other one. So that is the most important thing. So sometimes you may have to give combination therapy, continue with the combination therapy.
Okay.
So
yes, sir.
Sorry.
No,
Okay,
please.
sorry to jump in. One of my patient is a father of a doctor. So when I started pimavanserin for hallucination and all, then she read all the documents insert. So it says sudden death. So
yes, elderly.
sudden death. So I said okay, QT prolongation, but the
QT prolongation.
QT prolongation and sudden death. So they're at her father was towards the end of Parkinson's spectrum, advanced. He was advancing. He was hallucinating. So I discussed with her that whether this hallucination impairs well, how does this hallucination affect? Is it hostile? Is he jumping around, or is he harming to self or other? So no. So then I said no. Okay, then we should not take the unnecessary risks with the pimavanserin, because elderly patient, you don't know. It's like a weather in Shillong. No, it rains and suddenly it is very sunny. Yeah.
Yes.
Okay, the next
Okay.
question is, what about pain as a symptom? A lot of patients come with pain in the legs ascending up, which are very disabling. How to evaluate and treat them? Dr. Priyanka, would you like to take that?
Yes, am I
Priyanka?
audible? Yes. So
Yes,
pain
yes.
actually, pain is a very common symptom. First of all, you have to understand what the person means by pain. Many patients often refer to the off symptoms as pain itself. So first of all, optimizing the drug therapy and giving them an optimum dose of levodopa and ensuring that they're remaining on most of the time. That is the first thing that has to be ensured. After that, then there are other symptoms of pain. Most of these patients, they are elderly. So to look at the other causes of pain, that is it could be an orthopedic related problem, it could be due to osteoarthritis or a radiculopathy. That said apart, there are non-specific pain symptoms, which includes the autonomic symptoms also, and which is as an autonomic symptom and it's vague, non-specific. So sometimes these pains they follow the criteria of restless leg syndrome also. So looking at the deficiency, iron deficiency, and looking at that also needs to be addressed. So first thing is to acknowledge the symptom and then to analyze where this pain is stemming from. Then for treatment of this pain, we can use drugs depending on the drug list and the profile of the patient. Sometimes we use pregabalin or gabapentin, and sometimes even SSRIs are also helpful in pain.
Another
Yeah.
drug is perampanel. Very low doses of perampanel can work wonders in these patients, 2 milligram. Because the pain has a glutamatergic stuff, so anti-glutamatergic drug can be beneficial. This is in addition to the gabapentin and pregabalin, especially in RLS.
To add to it, most common type of pain is back pain. So whenever the patient complains of back pain, you should make sure that patient has no axial rigidity. So you increase the levodopa a little bit, the axial rigidity will come down and back pain will subside in many patients. So whenever patient with early Parkinson, especially when they complain of back pain, you just try to increase the levodopa and see the response. That's very important, rather than adding a pregabalin or an analgesic.
Yes, so I think we can very well just pain can be a non-motor off symptom. So that what Priyanka was talking. So they do respond what Dr. Sujit also told. So it can be just try to see if that's an off symptom or if that's a non-motor fluctuation which is there, which can be addressed by this levodopa. And otherwise that, then of course there are other elderly disorders.
Just to add, sir, actually, if it is like a neuropathic pain, which is not uncommon in Parkinson disease, so we can add a pregabalin, gabapentin, and SNRI, SSRI group. And for the musculoskeletal pain, sometimes after optimization of dopaminergic therapy, NSAIDs, if not contraindicated, works. So we have to characterize the type of the pain and accordingly we manage. But the central role is usually to optimize the dopaminergic therapy.
Because this pain in PD is being studied in quite detail, and we had also done a study with PDA versus PSP also. So pain is one of the central, it can be one of the central symptoms, which may not even respond to your levodopa and may not even respond to your pregabalin gas. So that can be very bothersome at times. You're right.
Okay, what is the role of lubiprostone in managing constipation and how should it be dosed? So, anybody wants to take that? Okay, lubiprostone actually is a chloride channel opener and it works on the apical intestinal epithelium. So it can be given, it is actually available at a dose of 24 microgram. The dose is 24 microgram twice a day. It works in Parkinson's disease. There are studies which have showed that it works in 40 to 64% of patients have had improvement. But the current issue, it is available in India. The current issue is the cost. Almost like 15 tablets costs around 350 to 500 rupees. So it can be used. Having said that, we have tried multiple medications in constipation and most of them really do not work very well. And I think still the bisacodyl is one of the drugs which works very well. One of the oldest drugs which works still. So lubiprostone can also be tried in patients who have Parkinson's disease.
The initial, what you have to tell is ask them to drink a lot of water. I generally suggest after 5 p.m. 5 glass of water, because many patients don't want to go to the toilet and they will reduce the water intake. That is the most important reason for constipation. So you first increase the water intake and see how most of the cases initially, because once we start some drugs, because they become dependent on that, and after some time it will not work. That is in constipation.
And
So
in
what is the
disease? It requires modification, lobiprostrone. I exactly don't remember the dose, but requires modification in liver disease.
And I think Balaji has very nicely said the dietary modifications, like to avoid constipation causing diet. So that lot of fibers. Yes.
Yeah. So what is the next question is what is the maximum dose of Syndopa? I guess it's Syndopa or Syncapon or whatever. What is the maximum dose? So I think there is no recommended maximum dose
No,
for
entacapone.
levodopa. Entacapone is all.
No.
Entacapone is 1,200 to 1,600.
Entacapone is something which probably you cannot give more than 8 tablets usually.
So 1,200.
So that I think if they're asking for Syncapone, then you should not go more than. Yes. I think that probably might, because it's not very clear. As you rightly said.
Yeah. Syncap. If you're talking about Entacapone, this is
Take the next
1,200 to 1,600.
Yes,
Levodopa alone has no definite recommended dose.
No,
but
definite, correct. No, I mean, the people have gone even up to 2 grams, so that is not something. But then, of course, you have to titrate it based on the side effects and other things. You cannot just keep on going titrating it up all the time.
Yeah. So the next question is genetic testing in Parkinson's disease. When do you recommend? I think Dr. Lakshya has answered that question. So you could just.
Divya, I have already mentioned a couple of things. No, the most important thing now in the current scenario in the DBS, no. So people they tend to do all the genetic tests before they perform DBS, because some of the genetic phenotype, monogenic genetic disorder like GBA, SNCA, and they perform not as good as other genetic variants. So before they put the patient on the DBS, then they counsel that you may not get the best response with the DBS. And that is one. And second, when a patient wants to know what is the risk of genetic disorder in his sibling or offspring. So that is the second one. And when we have certain atypical clues like a dystonia, early onset PD with dystonia, so that may signify that we are maybe dealing with the monogenic genetic disorders. And another one is a very young onset the Parkinson is say less than 50 years of age, and but there is no definite guideline that when we should in what context we should perform this genetic test. Yeah.
I think
Which
that answers.
perform with the counseling also, because it can cause unnecessary and added tension to the family, like whether the sibling or whether the children will have Parkinson's disease, we are still not very clear about it. So we often forget the counseling part, and that is very much necessary as to why we are doing and what implication it is going to have, a positive result or a negative result.
Yeah. So famous example is the one. He was a CEO of Google. Okay, and he has donated the highest amount of money for Parkinson research, GBF, for GBA research, because his mother was Sergey Brin. So his name is Sergey Brin. He was the top boss of Google. Then his mother was found to have a GBA mutation, and she was a Parkinson patient. Then he wanted to know himself that whether what is the chance of getting Parkinson in me. Then he tested himself, and he got it found. He became positive. He found to be positive. So then the high means he is the one who I think till now in the world have donated. He donated 1 billion for research in GBA, because he wanted to find a cure for Parkinson related to GBA. Yeah.
Yeah. So coming to the last question, is Mirtaz a good antidepressant? How effective is melatonin? And do rasagiline and safinamide work in a 10-year disease? So is Mirtaz a good option for an antidepressant? Are you there, Vaibhav? or Kaustubh. But Mirtaz is a good option as an antidepressant, especially with anxiety. It can be used. It is safe. Like it is not having any D2 blocking action, can be used. How effective is melatonin for sleep? Melatonin has a very short duration of action, and hence it does not give I mean, the onset may be okay, but generally it does not give a good effect for sleep maintenance, insomnia, and not maybe practically it's not very effective. You can go for other options. We usually give benzodiazepines. Even lamborexant is a good option in patients who do not have sleep. And always ensure that there is no nocturnal echinacea, which is one of the important causes where the sleep is disturbed. And nocturia, if present, also needs to be treated. And do rasagiline and safinamide work in disease of 10 years duration? Would anybody would like to take that? Do rasagiline and safinamide work? So rasagiline basically is a very weak. Yeah, sure. Ella.
Yeah, so rasagiline and safinamide, they can be used. It is not strictly contraindicated, but the issue is they are not as effective as levodopa. Like for example, one pill of 1 milligram of rasagiline if you translate it into LEDD, it would be like 100 milligrams of levodopa. So we need to see what is the issue. Is it the motor fluctuation? And how much bothersome that symptom is for a patient who is having 10 years of disease. So, if the patient is already on optimized doses of levodopa and you want to have a slight add-on, then you can try rasagiline, but it is not going to be like a magic bullet in such a situation, even safinamide for that matter. But some studies like say that safinamide has good effect on dyskinesias. But then again, you need to weigh whether you want to just keep pushing with adding some minimal amount of drugs in a 10-year duration of illness, or do you want to step up and go to something like a device assisted therapy like DBS or apomorphine pump in that situation. So that is something in which you need to have shared decision making between the patient as well as the patient caregiver, and the physician has to sort of find the sweet spot where maximum efficacy can be attained.
I think that sums it up. Like levodopa is still, the LEAP study has very much just put the last nail in the coffin. Levodopa is still the key for most of the patients if you want to have good functionality. And then after that, you can have a lot of add-ons, but at the same time, you have to keep in mind the side effects. And yes, rasagiline, the trials have shown initially that there was some benefit, but then probably it was just the neuroprotective benefit was quashed in the same study. So I don't think there is much to really boast of, but of course you can try, but then probably levodopa and then of course the device, this deep brain stimulation. These are the two main things which probably you have to play with at the end of the day.
So I think, we can
think
close
we can,
the questions with that.
But it's already, we have short the time by more than 60 minutes now. So before the panelists are angry and they leave us and our speakers, they go away.
Can we just
should
have a
close it.
photo before, like, can all of you please switch on your video?
Yeah.
Kaustubh and Ashish, if you're there.
I think Achal sir has left, but I think most of us are there. Divya is there. Divya,
Yeah,
Emma.
Divya is there. I think Kaustubh and
So
Kaustubh
you can
is
just
there.
you can just take us.
Ashish is there. Yeah, I'm just saying. Kaustubh, are you there?
Vaibhav is missing.
Vaibhav is missing.
Ashish has started enjoying.
Yeah, so in 3, 2, 1, just I'm taking a snap. Please smile. Okay, one more. Ashish, can you just move your hand? Ashish. Yeah, thank you. So I think Neeraj sir, we can wind up. You can give an official.
We are very highly thankful to all
I'm
our
actually supposed to
panelists.
see the patient now.
Yeah. No. Yes, you please, you carry on with your routine work, Ashish. I think we are all done. And thank you for all the time which you have spared, and all the panelists, all our speakers, and all the others who have contributed, the ones who have asked questions, all those. And I think we can wind up, Divya.
Yeah, we had almost up to 100 participants who have been here on a weekend for spending almost 2 to 3 hours from their busy schedule. So without the delegates, this session would just wouldn't matter at all. So thank you all the delegates specifically for spending so much time and being part of this program. I thank all the panelists and the speakers who have put in a lot of effort to make their slides and make this program a grand success. I should thank Dr. Neeraj, who has been a constant encouraging force for me to do something and put things. And he's a very excellent person to work with. So thank you, Dr. Neeraj, and thank you all the panelists and the speakers and each one of the delegates for being a part of this session. Thank you. Thank you very much.
Thank you. Thank you all.
Good night.
Good night.
Good night. Good night.